Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and whether you're here as a nursing student, getting ready for the NCLEX, or getting ready for nurse practitioner school, I hope this series is going to help you. In this roughly 8-hour series, we cover almost the entire nursing pharmacology curriculum. Keep in mind, all of the notes that we're using in this lecture and in this whole series are available on our website. I encourage you to print them, follow along, and put comments on all the additional information that is brought forth in the audio section of this lecture. So we're going to go ahead and start. And today we're on video number 2, and we're going over analgesics. So we're going to begin by talking about opioids. Opioids, the technical drug class, is opioid agonists, and this includes a lot of both legal and illegal drugs. The legal drugs are going to be fentanyl, hydromorphone, morphine, codeine, and so much more. The illegal version of the exact same drug class is going to be things like heroin. The mechanism of action of these drugs is that they are opioid receptor agonists. They activate opioid receptors. This results in decreased pain and decreased central nervous system function. What do we use this for? Opioid agonists are used almost exclusively for pain. However, we do also use them as an add-on for sedation. We also use one specific one which is codeine, and we use that for a cough. We also use the concept of opioid agonists to treat diarrhea by inducing constipation, and that will be discussed when we get to GI. So let's talk about the adverse effects and side effects. Probably the most famous side effect of opioids is that they cause constipation. They slow down peristalsis, which means they slow down how quickly things move through the GI system. And when things move really slow, a lot of water gets pulled out of it, and all that's left in our GI system is a solid lump, hence constipation. Other things that we may see develop is respiratory depression. Nausea is very common, as well as sedation. Now, I want to go over each one of these because, again, we're trying to prepare you, whether it's for school, whether it's for the NCLEX, whether it's for nurse practitioner school. You have to be able to really understand each of these and understand how you're going to see them on a test. For example, constipation. You may not likely see a simple question like, which of the following do opioids cause? What would you see? You would see a question like, a patient is on morphine. Which of the following would be a correct patient education point? And they're going to ask you to teach the patient something that prevents constipation because they expect you to already know that this drug causes constipation, and they expect you to already know what is the patient education to prevent constipation. So an example question would be, which of the following is an appropriate education for someone prescribed morphine? And the answer would be something like increase your fluid intake or increase your activities, because both of those are non-pharmacological interventions for constipation. And that'll be covered in GI, but I want you to understand how to start preparing for yourself for the test, especially if you're taking the NextGen NCLEX. Another example would be nausea. So if this medication causes nausea, then you're going to have your patient tell you if they begin to feel this. What's an assessment you would do? You would look out for signs of nausea and vomiting. Do keep in mind, years ago, every time we gave someone an analgesic, an opioid specifically, we automatically gave them an anti-nausea medicine. That is not considered best practice anymore. Respiratory depression. Again, it's not going to be a simple question like, what does this drug cause, respiratory depression? It's going to be, what's your priority assessment to look out for adverse signs of this drug? And that would be something like a respiratory rate or lung sounds or respiratory depth or a pulse ox. All of those are fair game questions to ask, and all of it comes back to this respiratory depression. Again, keep in mind, for everything you see in pharmacology and throughout your education, if it's respiratory depression, it's not going to be a simple question. You have to be able to play with it and understand what type of question it's going to look like. For sedation, same thing. What would you be looking out for? Well, you'd be looking, or what would you tell the patient to look out for or to expect? Well, sedation equals fatigue. It equals drowsiness. It equals sometimes weakness. And that some of that might be stretching it a little bit, but that's what the critical thinking, the NextGen aspect is going to be looking for. All the opioids are controlled substances. They're all going to be Schedule 1 or Schedule 2. Heroin would be an opioid that's a Schedule 1. The ones we're going to be giving in the hospital are going to be a Schedule 2. The opioids all have 3 black box warnings. One is to avoid alcohol and other CNS depressants. Remember, these already depress your CNS. If I add alcohol on, which is definitely a CNS depressant, that's going to amplify the effects. In terms of respiratory, we already discussed that it causes respiratory depression, and not only that it causes it, big black box warning, look out for it. Almost everyone who dies of an opioid overdose, they died because they stopped breathing. You stop breathing, a few minutes later, you're dead. That is what kills you. That's what we can intervene. Theoretically, if someone overdoses on an opioid, but you're sitting there with a bag mask, giving them proper ventilations or putting them on a ventilator, then they're okay. The biggest issue is that respiratory depression. If we address that, then we can massively impact positively the patient's outcome. The third black box warning goes with almost everything that's on the controlled substance list. Risk for abuse and dependency, we already know that. Now, if a patient does get an opioid overdose, we treat that with naloxone, which is Narcan. In some states, Narcan is actually available over the counter to make it more readily available. Keep in mind, it really can't hurt anything. All it does is it is a opioid antagonist. We talked about that in our very first video. An opioid antagonist blocks opioid receptors. So if I had picture an opioid receptor as a parking lot, some heroin pulled up and started a party, Narcan, or the opioid antagonist, comes in, kicks them out, shuts that gate down, so now that effect is no longer happening. So again, these are opioid antagonists. Remember, every time you give a drug, you're going to assess the patient before, you're going to assess after. So if you give them morphine, you're going to assess their pain level before, you're going to assess their pain level after. You're also going to assess their level of consciousness. You're also going to assess how alert and oriented they are. Remember, anything the drug impacts, like their CNS, you need to assess it beforehand. You need to reassess it after. Same thing with giving a patient naloxone. As we said, the number one reason why we would give a patient naloxone is respiratory depression or just stop breathing related to opioid use. But a lot of times we also use naloxone just as a shot in the dark. This patient's unresponsive. I have no idea why. Let me give them some naloxone and find out. If they now wake up, great, I have my answer. Not great, but I have my answer. It's because of an opioid overdose. If they're still asleep, again, not great, but I have my answer. It's not an opioid overdose. Or it could be it is, just mixed with other things. So again, naloxone is an opioid reversal agent. Technically, it's an opioid antagonist. How does it work? It kicks the opioid out of that receptor cell that it was parked into and it was livening it up. It kicks it out, shuts the party down. When do we use it? Primarily related to respiratory depression due to opioid overdose, but we can also just use it as a shot in the dark. Let's see why this patient is unresponsive. Remember, the key here is that we're going to be doing it related to their respiratory depression, so we must assess and look out for signs of respiratory depression. Keep in mind, every patient who is receiving opioids, you're going to watch their respiratory status. That means pulse ox, that means lung sounds, that means all of it to make sure they're still breathing. The number on the monitor does not tell you everything. They're still breathing 12 times a minute, but now instead of breathing in 500 cc's of air, they're only breathing in 100 because they're barely moving any air. That is a big problem, and that is something that you need to be monitoring for. Lung sounds would be one way to do that. Respiratory depth would be another way to do it. Chest rise would be another way to do it, and so on. Speaking of opioids, let's keep going. They are produced often in combination drugs, specifically with acetaminophen. One example, very famous, is Vicodin. Vicodin is a combination of an opioid, hydrocodone, and a non-opioid, acetaminophen, Tylenol. And what's the reason here? The reason is we thought that if we give a little bit of acetaminophen with your opioid, then I'll need less opioid. And that is correct. However, keep in mind that now we may be giving you too much acetaminophen. We have lately started paying attention to this phenomenon that when we're giving these patients, yes, we're now needing a lower opioid dose, but now we're exposing the patient to so much more acetaminophen, which we do know is harmful. Tramadol is another opioid. It is sometimes considered an opioid. It's sometimes considered a non-opioid. I just want to throw that in here because depending what school you go to, what textbook you're using, what resource you're using, sometimes considered an opioid, sometimes it's not. So if you see that in various places, don't let it confuse you. Pain relief should not be withheld due to suspicion of addiction. And this can't be overstated. It is not your role as an RN to determine whether or not a patient deserves to get treated for their pain. You are going to assess the patient, you're going to document, you're going to not blindly do it, but you're also not going to withhold a drug on your own authority because you feel that the patient is just here drug seeking or something like that. You discuss it with the provider, let them make a decision. PCA, patient-controlled analgesia. This is also known as a pain pump. This is where the patient has that button that they can click for an extra dose. I'm sure all of you are familiar with this. If nothing else, it's been on so many TV shows. And what is it? It's meant for patients that have chronic pain, or at least are going to have pain for a specific amount of time, let's say post-op. In this case, the patient gets, let's say, morphine every 4 hours, but then the pump gives them a little bit extra. And what's the benefit here? Two things. First of all, when a patient has what's called breakthrough pain, that's where they're on a pain medicine, but it's just not enough for this period of time. Right now, it's just not enough. I need something more. This allows them to get something more without having to wait, press the button, call the nurse. The nurse has to go check the chart, run to the Pyxis, grab the medication, assess the patient, give the medication, and the patient's sitting in pain the whole time. No, this allows the patient to, on their own, give themselves an extra dose when needed. It is safe in terms of the patient's not going to overdose themselves as long as the machine is set correctly. Also, studies have shown that we'll give patients that control over their own treatment, such as their control over that extra pain medicine, that helps improve their pain overall. Remember what we said in the first video, all of this does not discount the need for you to independently offer non-pharmacological interventions, whether it's because the provider said they're not getting any pain medicine, whether it's because they got medicine and it hasn't kicked in yet, or even they got medicine and it kicked in, but they're still having a little bit of pain. You don't need to give them more medication. In all of these situations, it would always be correct, especially on a test question. When is it wrong to do a non-pharm intervention for pain? Never. It is always appropriate. And what do I mean by that? So let's go ahead and list a few. You for sure know these already if you're at any point in your nursing education, but let's list some. Turning on the lights, turning off the lights, lowering the noise volume, especially at the nurse's station. We can be loud, so lower it. Turn up or lower the light, the temperature in the room. Some patients like it cooler, that makes them more comfortable. Turning on TV, reading a book, music. How about talking to your patient? I know, crazy idea, but let's try it. We're nurses, we got into this for a reason. How about treating your patient and actually talking to them and distracting them from their pain, at least until the medication kicks in? How about changing the sheets? That's a simple, non-pharmacological intervention, and most patients, most people feel a little bit better when they're on a clean, fresh set of sheets. That's also a non-pharmacological pain intervention, in addition to massage and all those heat cloths, cold packs, all of that. Educate your patient on the risk versus benefit of opioids. Remember, you are going to have times where the provider prescribes the patient, let's say 4 milligrams of morphine. You walk into the room and the patient says, no, thanks, I don't want to have any opioids. And that's fine. However, it's your job to follow up and say, why is it that you don't want opioids? If they say it's because I used to be addicted, or they say because I don't believe in that, it's okay to talk to the patient. But most importantly, if the patient says it's because I'm afraid of getting addicted, it is your job to educate the patient that this dose has been prescribed. It's a safe dose. It meets the guidelines. The risks of addiction are very relatively low, and it is in your best interest to take this medication. Because there's two nurses out there. One nurse, the patient's going to refuse it as they're having this massive heart attack and they're in a ton of pain, and the provider ordered the morphine. One nurse may go and say, oh, you refuse it? No problem. Sign patient refused. Peace out. Have a nice day. You're not going to do that because your patient's still going to sit there in pain. What do you think pain does for that patient having a heart attack? Certainly nothing good. Probably a lot of bad. So you're going to educate your patient and you're going to explain to them that this is in their best interest. It's going to help them. And it certainly has a better reward versus the small risk of them becoming addicted. Let's move on to another medication for pain. This is a different type of pain. This is for migraines. The drug class here are serotonin 5-HT agonists, much more commonly known as the triptans. The triptan we're going to talk about is sumatriptan or Imitrex, but there are a few others. Brand name is Imitrex. And how does this work? Well, your brain is a confined space. Your skull is a confined space. And in there is blood, is brain, and a little bit of cerebral spinal fluid. But it can get pretty crowded up there. So when a patient has a migraine, one thing that we can do is we can vasoconstrict. That means we can make the blood vessels smaller. So if in this closed space of my brain, it's getting a little tight in there and I start to get a migraine or a headache, not any headache, but a cluster headache or a migraine. If I drain some of that blood out, now there's a little bit more room for the brain to breathe. Obviously, this is not exactly what happens, but you get the concept. The serotonin 5-HT agonists work by vasoconstricting the cerebral blood flow, that means the blood flow to the brain. It vasoconstricts, it shunts some of the blood out of the brain so that there's more quote unquote room up there so that things aren't getting as squished. It also it decreases perivascular inflammation, again, decreases the space that we're using up there so that the brain is not getting pushed on. This medication class is used for acute cluster headaches as well as acute migraines. A common complaint that patients get with this medication is that they feel heaviness on their chest. That being said, this medication is very common. It's relatively safe to use. It is meant to be taken as soon as they feel their headache coming on, because the sooner they take it, the better and more effective it will be. This is the first line medication for an acute migraine. Obviously, there's plenty of over-the-counter medications that most commonly patients would have tried by the time they get to us giving them prescription medication. But in terms of prescription medications, this is the first line agent. This can cause what's called a rebound headache if it's taken in excess. Generally, that means more than 2 days per week or more than 9 or 10 days per month, depending what textbook you look at. That being said, it is considered that this medication should not be given more than 9 doses per month. And that is generally the maximum prescribable amount for that reason, because we don't want to give this patient in excess, because if they start taking it too regularly, then anytime they don't have that medication, they get their migraines and they become dependent on it. And that's, of course, not what we want. This medication is teratogenic, which is unfortunate because migraines do occur more in females. However, this medication would no longer be available to the patient if they are pregnant or trying to become pregnant. Do keep in mind, anytime you see that alert, teratogenic, it would be fair game for a test, the NCLEX or any other test, to ask you which of the following medications would require a pregnancy test prior to administration. And this would be the answer. It's not just going to say what medication is teratogenic. It's going to take it a step further. It's going to say your patient's prescribed sumatriptan. What would be a required lab? And a HCG would be the correct answer. Again, it doesn't even have to say pregnancy test. It could take it a step further and go to an HCG. And that's how it's asking you, all getting back to the same information, that this drug is teratogenic. This medication, as you saw in the name, is a serotonin 5-HT agonist, which means it interacts with serotonin. And because of that, it can increase the effects of serotonin. Depending where you're at in school, you may not have covered mental health yet, but in mental health nursing, we know that serotonin medications can, if you take multiple of them, can cause what's called serotonin syndrome. In this case, because this drug does have some serotonin effects, we do need to look out and assess our patient for serotonin syndrome. Remember, every time before you give this drug, you need to assess your patient for pain before and after. And then afterwards, you're also going to be assessing for any side effects, such as serotonin syndrome, such as chest pressure or heaviness, because we said that's one of the side effects, all of these things. This medication is contraindicated, cannot be given in patients that have cardiac disease or uncontrolled hypertension, because in those cases, it causes more harm than good. Finally, if your patient does ever overdose on this and end up with serotonin syndrome, the treatment for that is giving them a beta blocker or a beta-1 adrenergic antagonist. I wouldn't expect this to be an RN level question, but it's a really useful piece of information to have because it's such a commonly used medication, and it is fair game on many tests. Next, we have NSAIDs. NSAIDs are one of the most commonly used, if not the most commonly used class of drugs, especially in the United States. NSAID stands for non-steroidal anti-inflammatory drug, and some textbooks will break it down into multiple subclasses, such as salicylates, aloxicams, and so on. We're going to lump them all together. What do we have here? We have ibuprofen, ketorolac, meloxicam, naproxen, indomethacin, aspirin, and there's plenty more. So how do these work? Their mechanism of action is that they inhibit cyclooxygenase, or COX-1 and 2. So what does this do? Well, COX-1 and 2 have a few functions. One of the things that COX-1 does is it develops the protective lining in our stomach. That's important to know, and you're going to see in a minute why. That's what COX-1 does, or one of the things it does. COX-2 is responsible for inflammation. Inflammation sometimes is a good thing, sometimes it causes pain. So when we give this patient, we are going to inhibit these two effects. We're going to inhibit that COX-1 from developing that stomach lining, and we're going to inhibit COX-2 from promoting inflammation. However, when it does this, it's going to cause some good things and some bad things. So let's go ahead and let's start looking at what these drugs are for, and then we're going to start to get into the adverse effects based on this mechanism of action. So what are these drugs for? First and foremost, they're an anti-inflammatory agent. That makes perfect sense. We just said COX-2 is responsible for inflammation. Specifically, it does it by releasing prostaglandins, which those cause inflammation, but we could probably skip that part for most nursing programs. So we're just going to focus on that COX-2 causes inflammation. However, this inflammation is not only what causes pain, it also has a lot of cardiac effects as well. So let's get back to this first use. Anti-inflammatory, yes, this drug is an anti-inflammatory agent. If the patient has an inflammatory disease, such as rheumatoid arthritis, such as gout, this is definitely going to help them. It's also used for pain. Again, if the patient's pain is caused by inflammation, which is relatively common, this medication works as an analgesic, as a pain medicine to help with that. And finally, this medication also works as an antipyretic. Pyro is the root of that word, and that means fire, just like a pyromaniac is someone who's very into lighting fires. Antipyretic means anti-fire or anti-heat or anti-fever. So this medication is also a fever reducer. Now, one medication on this list, aspirin, is also used for something else. It's used to suppress platelet aggregation. Platelet aggregation, you're going to learn about at some point if you haven't already, is where platelets come together, they aggregate to form the basis of a clot. So aspirin is also used to suppress that to make the person less likely to clot. And we'll talk more about this when we get to the anticoagulation lecture. However, for right now, let's just know that aspirin is the one NSAID that has an additional purpose in addition to anti-inflammatory, in addition to helping pain, in addition to helping fever. It helps stop a patient from bleeding from clotting. Also keep in mind, because it does stop clotting, it makes you more likely to bleed. So if your patient's on aspirin, you are going to look out for signs and symptoms of bleeding. And again, it's not going to be a straightforward question. NextGen wants you to really critically think, which of the following would I have to be extra cautious on in a patient that has aspirin? And it could be something like making sure to get the IV on the first time. And you need to make those dots. Why do I need to get the IV on the first time? Well, if I miss it, they're going to bleed. And this patient is going to bleed more than the next person because this one is on an antiplatelet. The black box warning, we have two of them for all NSAIDs. The first is GI bleeding. Now let's go back to the mechanism of action and figure out why. Because you already know it, because we're good. We know this. It causes GI bleeding because COX-1 is responsible for protecting the stomach from GI bleeding. But if I give you a COX-1 antagonist, if I block COX-1, then I'm going to make your stomach more likely to bleed, more likely to get an ulcer. And we'll talk much more about this in GI. But for right now, all of this should be making sense. If I'm giving you a drug that stops the body from protecting the stomach from developing a GI bleed, then this makes it more likely to develop a GI bleed. A GI bleed is the number one reason why we do not want these patients on these drugs for long term. It also has a black box warning that causes adverse cardiac effects. That's related to the interfering with inflammation, which a lot of inflammation is necessary and part of our standard practices in our body. And when we interfere with that, we can cause problems. And that's why, as a black box warning, that it can interfere with a few of our cardiovascular functions because it interferes with our inflammatory process. Some of these drugs are over the counter. Some of them are by prescription. I wouldn't expect you to ever get tested on that, but for the heck of it, let's review it. Meloxicam, which is Mobic, indomethacin, ketorolac, which is Toradol. Those three are by prescription only. The rest on this list are available over the counter. Obviously, because it has a black box warning for GI bleeding, you already know it can cause GI bleeding. It can also cause nephrotoxicity and hepatotoxicity. What do those mean? If you're watching this lecture in order, this series in order, this is the first time you've seen those terms. Nephrotoxicity, nephro, like nephrology, is related to the kidneys, so it's toxic to the kidneys. And hepatotoxicity, like hepatitis, relates to the liver, and that means that it's toxic to the liver. Again, remember, if you're looking at NextGen style questions, it's not going to be which of the following drugs is nephrotoxic. It's going to be which of the following drugs would I not give to a patient with an elevated creatinine? or which of the following drugs can accumulate in a patient that has CKD or something like that. Because again, it's going to look for the second level question. It's not going to look just what's nephrotoxic. It's going to be, how do I know it's nephrotoxic? So if I ask you on a test, what labs would I need to order before administering NSAIDs? Well, you better look at this and you better know, well, it's nephrotoxic. So that means BUN and creatinine I should be checking. And it's hepatotoxic. So I better be checking the AST and the ALT to see what's going on. One additional side effect, very famous, it shows up on a lot of test banks, is going to be tinnitus, which is ringing in the ears, and that's specific to aspirin. Aspirin is also not to be used in children under the age of 18 due to the risk of developing Ray's syndrome. Ray's syndrome used to be a big problem. It's very, very rare now simply because we've so well educated patients and parents to avoid using aspirin in children. NSAIDs are available through multiple different routes with different onsets. You may need to know that for a test. If you give a patient a Advil PO and it asks you, what are you going to tell the patient? If you're going to tell the patient, well, I'm going to give you this medication, I'll be back in 10 minutes to check on you, that is wrong, because a PO medication does not have an onset of 10 minutes. You need to recognize that, especially for NextGen style questions. So if the patient 10 minutes later tells you that I developed a adverse effect, is that related to the medication? Well, it depends what it is. If it's something that needed the medication to process in our GI system, then no, it hasn't processed yet. So again, always make sure you're paying attention to the route and how long it takes to kick in that route. Because if I give a patient a PO med and I say, I'll be back in 10 minutes to check on your pain, that's wrong. Or if I give you an IV medication and I say it's going to kick in about 30 minutes, that's wrong. You have to understand the time of onset for each of these drugs. Next, we have a subset of NSAIDs, which are the COX-2 inhibitors. We said that all the NSAIDs inhibit COX-1 and COX-2, and that the primary goal of it is to inhibit COX-2. We do have one drug that does. It only inhibits COX-2. Why is that an advantage? Well, it's an advantage because we said that COX-1 is going to cause problems with our GI. This doesn't do that as much. That's a good thing. So what's the drug here? It's celecoxib or Celebrex. That's the only drug in this class that's available in the United States. What is this used for? It's used for anti-inflammatory. It's not used for fever. It's definitely not used for antiplatelet. It is only used for anti-inflammatory. And it's used for inflammatory conditions such as rheumatoid arthritis. It's also used for osteoarthritis and a few other things. Keep in mind one very important thing. This may be counterintuitive. This drug is not a first-line agent in almost all cases. Why? Because this drug has a high risk of causing adverse cardiac events. You'll remember we said that these drugs, the NSAIDs, have two black box warning. One is GI bleeding, and that's because of COX-1, and one is adverse cardiac events, that's because of COX-2. In this case, yes, we lose the bad part of the COX-1 inhibiting, and we lose that disadvantage of GI bleeding, but we pick up more so of that adverse cardiac risk, and for that reason, this is not generally considered an ideal drug. We would rather use something else, if possible, that's safer. That being said, this is obviously an approved drug, an available drug, and a drug that is helping a lot of people. Finally, the last one that we have for this lecture, and before we go into that, since you are still here and watching this video, please make sure to hit the subscribe button to this channel. All of the content that is here is offered completely free as a resource for you, for nurses, for nursing, for nurse practitioner students. All you have to do to support our channel is to hit the subscribe button and enjoy the channel. The last drug that we're going to talk about here is the central acting antagonist, and that is acetaminophen or Tylenol. You may also see APAP, APAP, as another abbreviation for this. That's an older term that we used to use. The mechanism of action for this is not fully understood, not as well as NSAIDs. We do know that it inhibits COX at the central nervous system level, and for that reason, it does cause the same relief of pain and the same anti-fever that NSAIDs do. However, this drug does not have the same anti-inflammatory properties. It has a tiny bit of anti-inflammatory effects, but not nearly as much as NSAIDs. This is not, for testing purposes, this is not considered an anti-inflammatory. It's an analgesic and an antipyretic, but that anti-inflammatory, that third part that we said NSAIDs do, this one does not do it. This one only does the pain and the fever. Black box warning, it's got one of them for hepatotoxicity. Notice that it doesn't have the GI bleed. issue, and it doesn't have the nephrotoxicity issue. So if you get a question on your test, which of the following over-the medications would be best for a patient? It gives you a whole long history, and one of the items in there is kidney disease. Well then, NSAIDs would be worse because NSAIDs are nephrotoxic. This one is not. So this would be preferred in a patient that has a kidney disease. Or it could be asked, which of the following in a patient with an elevated creatinine, which medication would I prefer, NSAID or acetaminophen? Again, it would go back to the acetaminophen because this one is not nephrotoxic. Remember, it is not an anti-inflammatory. So if you have a disease like rheumatoid arthritis or something like that, that is an inflammatory process, this medication would 100% be the wrong answer to give for that patient. Because of the way it works, it does have a big advantage that it doesn't have that massive risk of GI bleeding that we have with other NSAIDs. Do keep in mind that even though you're learning all this stuff and now you understand that there's a risk of GI bleeding, there's also a risk of driving your car. Don't ever think that, oh my God, I'm never going to take this again because it's so bad. As long as it's taken within reason, it's not taken extended periods of time for an extended length of time. Generally, all these medications are relatively safe depending on your other underlying conditions. Don't let, now that you're learning about this stuff, don't let it scare you off. Finally, an acetaminophen overdose, which is one of the most common, if not the most common, intentional overdoses of medication in the United States, is reversed with something called N-acetylcysteine. Also keep in mind, if you overdose on acetaminophen, what organ is that going to hurt the most? You got it. Because the black box warning, I know that it's going to hurt the liver the most. So that's what I'd be monitoring. So if I ask you what do you need to monitor based on the adverse effects of acetaminophen overdose, if ALT or AST is the answer, or jaundice is the answer, or liver inflammation, any of those things would all come back to hepatotoxicity. All of those would be correct.